Let's continue with our discussion about your carbohydrates. Right now, we'll be discussing about the clinical correlation. So we will be discussing the different disorders related to your carbohydrates. Of course, you are familiar with one important disease in your carbohydrates, your diabetes mellitus. So right now, we will be discussing ano ang mga pathogenesis, the clinical manifestation, the different criteria, and how do we diagnose this different disorder. So again, when we say hypoglycemia, there is a decreased plasma glucose levels. When we say hyperglycemia, that refers to increased plasma glucose levels caused by an imbalance of hormones. Of course, not all hyperglycemia, and I mean hyperglycemia is not the disease per se, but rather it could be a manifestation of a certain disorder. Not all hyperglycemia is brought about by a disease. It could be a physiologic phenomenon, including by your hypoglycemia. Kumbaga, baka kulang ka lang sa pagkain kaya nagkakaroon ka ng hypoglycemia, or kakatapos mo lang kumain kaya nagkakaroon ka ng hyperglycemia. But there are a lot of conditions, but your hyperglycemia or hypoglycemia could be a manifestation of a certain disorder. And also, there are different inborn error of your carbohydrate metabolism. I know you already discussed this in your biochemistry related to the glycogen storage diseases. So as the result of a deficiency of your specific enzyme that causes an alteration of your glycogen metabolism. Of course, we will not deal with that anymore. It's too technical and sobrang dami. But what thing that we will really focus more in our clinical correlation is really your diabetes mellitus and our hyperglycemia. But first, let's talk about your hypoglycemia. There are a lot of conditions that is related to your hypoglycemia. It could be meron kang insulin overdose or a reactive hypoglycemia, or postprandial hypoglycemia brought about by a GI surgery or a mild diabetes, or could be a fasting hypoglycemia resulted from your insulin-producing pancreatic islet tumor or your insulinomas. So therefore, you are creating more insulin resulting into hypoglycemia. And also, you have your hepatic dysfunction and your ROH consumption. So again, excessive alcohol. So this is now your alcohol consumption. Excessive alcohol consumption, drinking heavily without eating, can block your liver from releasing your stored glucose into your bloodstream. That's why your alcohol consumption will cause hypoglycemia. Now again, for your hyperglycemia, ito talaga ang pinaka-bulk ng ating discussion in terms to the clinical correlation of your carbohydrates, because ito talaga ang pinaka-common na dapat nyong malaman. When we say diabetes mellitus, it is not just a disease, one disease, but actually it refers to a group of common metabolic disorder that shares the phenotype of your hyperglycemia. So therefore, diabetes mellitus is not just one disease. It's a group of common metabolic disorder. That's why meron tayong iba't ibang uri ng mga or classification ng diabetes mellitus. We will discuss that later. Depending on the etiology, factors contributing to your hyperglycemia include pwedeng reduce ang insulin secretion, pwedeng decrease glucose utilization, or increase ang glucose production. But all of these factors will lead to hyperglycemia, which may lead to your diabetes mellitus. Again, pag mababa ang insulin, reduce insulin, therefore, tataas ang glucose level. Pag mababa or decrease ang ating glucose utilization or hindi ginagamit ang ating glucose, therefore, mataas pa rin ang glucose sa ating katawan. Or, pwedeng marami ang production ng ating glucose. So again, lahat ng factors na ito will lead to increase or hyperglycemia. There are several types of your DM are caused by complex interaction of your genetic and environmental factors. So na sinasabi ko, daming factors that will lead to diabetes mellitus. It could be genetics. We all know some of us, our parents are diabetics, and most probably, if you will not have a healthy lifestyle or other factors, then most probably you will also lead into diabetes mellitus. Both of my parents are diabetic, and right now my sister is already having a symptoms of diabetes mellitus. So, most probably, in due time, baka ako rin magkakaroon ng diabetes mellitus because it's an interaction between environmental and genetic and genetic factors. Again, the metabolic dysregulation associated with your diabetes mellitus causes a secondary pathophysiological changes in multiple organ system, and it imposes a tremendous burden to the individual with diabetes and to the healthcare system, because we all know diabetes mellitus will have different complication. Sa lahat ng sakit, ang diabetes ang napakaraming complication. It will lead to several disorder through time. Through time, it will affect your eyes. You could have your cataracts or glaucoma. You could also have kidney problem later on, liver problem, entire or different or complex system problem. That's really a worst case scenario of having diabetes mellitus, because it is a multiple organ system that can be affected by your DM. So these are the different types. Overview of the common types of your diabetes. Meron tayong type 1, meron tayong type 2, meron tayong other specific types. We have your gestational diabetes. So these are the different types of your diabetes. 1, 2, other specific types, and your gestational diabetes. And if you can see this is the time frame of the different classification of your diabetes. Your type 1 through time, from a normal glucose tolerance, pwedeng magkakaroon ka na ng insulin requirement for survival. For type 2, pwedeng from an impaired, magiging normal na naman siya, or it may lead to insulin requirement for control. Or for your gestational, somehow similar with your type 2. Again, this is a time frame of in terms of how the progression of your glucose problem or failure will happen, leading to your diabetes mellitus. And this will be now the different laboratory criteria for us to diagnose whether it is diabetes, pre-diabetes, or just a normal glucose tolerance using these three important tests. We have your fasting glucose, we have your 2-hour postprandial glucose, and your hemoglobin A1C. These different laboratory diagnostics will be discussed thoroughly in your laboratory, kasi nga doon na yung laboratory applications of your carbohydrates. I-discuss ito isa-isa, yung fasting glucose level, yung 2 hours postprandial level, and your hemoglobin A1C. But we have to be very careful of the values. Pag sinabi natin normal glucose, pag fasting glucose lang, dapat the normal value is less than 5.6. Pag impaired na yan or a pre-diabetic state, that could be 5.6 to 6.9. But if it's already diabetes mellitus, that's gonna be more than 7 millimoles per liter. So kindly take note of these values. It's very important that you have to take note of these values. So again, if you see your Harrison's internal medicine book namin sa medicine, these are the different classification or etiologic classification of diabetes. Dati alam na natin, DM type 1, type 2, but basically speaking, marami pang mga specific types of diabetes. Meron tayong caused by a genetic defects of the beta cell or gene defect. Pwedeng transient neonatal diabetes, or pwedeng diseases of your exocrine pancreas, brought about by pancreatitis, pancreatotomy, ang sobrang dami. Or it could be a genetic defects of your insulin action or different endocrinopathy. So, pagdating natin sa endocrinology, sa ClinChem CC2, we will be discussing your acromegaly, your Cushing syndrome. You will discuss that, or you will learn more about that. Pwede siyang drug or chemical induced, pwedeng brought about by certain infection, or immune-mediated diabetes, or other genetic syndrome. And the last classification is your gestational DM. Of course, we will not be able to go into the different or specific types of diabetes. Ang pinaka-importante at your level right now is to classify the difference between type 1 versus type 2 DM. Yan lang talaga ang pinaka-importante for now. But later on, as time goes by with our discussion sa ClinChem 2, some of these mga different disorders, you will learn that hyperglycemia could be a manifestation of these different diseases. And for now, ang discuss muna natin, type 1, type 2, and your gestational diabetes mellitus. Okay? So na, again, paulit-ulit na lang to. Diabetes can be classified in the following general categories. So let's first discuss your type 1 diabetes. When we say type 1 diabetes, this is due to autoimmune beta cell destruction, usually leading to absolute insulin deficiency, including latent autoimmune diabetes of adulthood. So basic lang, it's brought about by a beta cell destruction, autoimmune beta cell destruction. Your own cell is attacking the beta cell. So therefore, it's one's self ang nag-aatake sa ating beta cell. So it is an autoimmune beta cell destruction. Remember, your insulin is being produced by the beta cell. Once it is being destroyed, therefore, bumababa ang ating insulin. There will be insulin deficiency. So again, type 1, there will be, it's caused by autoimmune beta cell destruction. How about your type 2? Due to a progressive loss of adequate beta cell insulin secretion, frequently on the background of insulin resistance. So therefore, meron kang insulin pero nagre-resist ang ating katawan. So therefore, kahit marami kang insulin pero hindi pa rin nagre-react ang ating cells on that insulin. So therefore, wala pa ring effect. Tumataas pa rin ang ating sugar level. Kasi hindi nakakapasok ang ating glucose inside our cell. So if we have to differentiate type 1, type 2, type 1, autoimmune, brought about by beta cell destruction. Therefore, there is insulin deficiency kasi sinisira mo ang ating beta cell. Type 2 diabetes, nagkakaroon ng insulin resistancy brought about by several factors. Kasi kahit meron kang normal level of your insulin but your body is resistant to that insulin, so therefore, wala pa rin nangyayari sa glucose na sa ating katawan. Therefore, mataas pa rin ang level ng ating glucose. All of this type of diabetes will lead to hyperglycemia. Of course, diabetes nga, hyperglycemia. And again, yung specific types of diseases, other causes, yun yung nakita natin na sobrang maraming factors. And lastly, we have your gestational diabetes mellitus. So this is a diabetes diagnosed usually in the second or third trimester of your pregnancy that was not clearly overt diabetes prior to gestation. So kaya nga nakikita natin yung mga mother nag-undergo ng prenatal check-up. So later on, malalaman nyo sa laboratory kung ano ang mga usually na nire-request for pregnant patient. And the procedure on how to properly instruct those patients, malalaman nyo yan sa laboratory application. So again, let's classify. Type 1 diabetes, it could be a complete or near total insulin deficiency. Kasi nga, sinisira ang beta cell. It could be merong total loss of our insulin or near total loss. Type 2, because of a lot of variables leading to insulin resistance. And for GDM, insulin resistance related naman sa pregnancy. And the different specific types, these are the different problems that we encountered a while ago. Again, so let's proceed with your type 1 and type 2. So your type 1 diabetes result from complete or near total insulin deficiency. Again, paulit-ulit na lang tayo, Doc Von. memorize na natin to. Your type 2 DM, again, it is a heterogeneous group of disorders characterized by a variable degree of insulin resistance, impaired insulin secretion, and increased glucose production. Your type 2 DM is preceded by a period of abnormal glucose homeostasis classified as your impaired fasting glucose or impaired glucose tolerance. Always be reminded that your type 1 and type 2 DM are preceded by a phase of abnormal glucose homeostasis as the pathologic process progresses. So, nag-uumpisa muna siya as an abnormal glucose homeostasis. However, there is an increasing recognition of other forms of your diabetes in which the pathogenesis is better understood. These other forms of diabetes may share features of your type 1 or type 2 DM. So, may mga sakit, ibang mga different forms of your diabetes that somehow have a similar pathogenesis with your type 1 and your type 2. So, now we will start our discussion with your DM type 1. So, your DM type 1 is the result of the interaction of genetic, environmental, and immunologic factors that ultimately lead to the destruction of your pancreatic beta cells and insulin deficiency. So again, destruction of your pancreatic beta cells. Sinisira ng sariling katawan natin yung beta cells. It can be developed at any age but develops mostly commonly before 20 years of age. So therefore, age of onset, usually younger age, before 20 years of age. So individuals with genetic susceptibility are thought to have a normal beta cell mass at birth. So usually pag may mga marami kasing factors why nagkakaroon tayo ng DM type 1, and one important factors is genetic susceptibility kasi nga it's brought about by autoimmune destruction. So at first normal beta cells pa sila. Meron silang normal pancreas at birth but begin to lose your beta cells secondary now to your autoimmune that occurs over months to years. This autoimmune process is thought to be triggered by pwedeng infection factor, infectious, or pwedeng environmental stimulus and to be sustained by your beta cell specific molecule. Later on, meron tayong magandang pathogenesis for this one para mas lalo nyo maintindihan. Ito na pala. Nakasabi ko lang. So this is now the diagram that will explain the pathogenesis of your DM type 1. Again, this is the reason why nagkakaroon tayo ng bakit sinisira ng ating own cells ang ating beta cells. Again, because of possible genetic predisposition and environmental factors. There are a lot. This is not limited to these two factors. There are a lot of factors that will lead to the destruction of your beta cells. Again, one important factors, genetic predisposition and your environmental factors. Your autoantigens form on insulin-producing beta cells and circulate in the bloodstream and lymphatics. Again, autoantigens forms on your insulin-producing beta cells. So therefore, merong namumuong autoantigens and this will circulate in your bloodstream and your lymphatics because this is brought about by genetic predisposition and environmental factors. And then, it will be processed and presentation of your autoantigen by your antigen-presenting cells. Remember, di ba? Yan yung function ng ating mga APC. We have so many APCs, especially your mga macrophages. They will present the antigen. Saan nila ipipresent ang ating mga antigens by your antigen-presenting cells? They will present that to your helper cells. Could either be your T helper 1 cells and your T helper 2 cells. Anong nangyayari? Once they presented that, it will activate your T helper 1 lymphocytes to produce your different cytokines, pwedeng interferon gamma and interleukin 2. For your T helper 2 lymphocytes, once activated by your antigen-presenting cells, it will produce your interleukin 4. Each of these cytokines being produced will result in 2. Pag interferon gamma, there is activation of your macrophages with release of your interleukin 1 and tumor necrosis factor alpha. And your interleukin 2, anong ginagawa ng interleukin 2? Activation of your autoantigen specific T cytotoxic cells. So, gumagawa siya, ma-activate yung CD8 cells or cytotoxic cells. And lastly, your interleukin 4 will cause the activation of your B lymphocytes to produce islet cell autoantibodies and anti-God65 antibodies. All of these factors will lead now to the destruction of your beta cells with a resultant of decreased insulin secretion. That is the basic pathogenesis of your DM type 1. From the genetic disposition unto the production of the different cytokines and will result into the different factors leading to now the destruction of your beta cells and increased insulin secretion. So that is a basic pathogenesis. Now, let's proceed. You were able to understand how type 1 diabetes, anong nangyayari sa type 1 diabetes. Ngayon, let's proceed with your DM type 2. Your DM type 2 is characterized by impaired insulin secretion, insulin resistance, excessive hepatic glucose production, and abnormal fat metabolism. As insulin resistance and compensatory hyperinsulinemia progress, the pancreatic islets in certain individuals are unable to sustain the hyperinsulinemic state. So, usually in the early stages pa lang, the glucose tolerance remains near normal. Despite insulin resistance, because your pancreatic beta cells compensate by increasing your insulin output. Again, you see, at an early stage, kahit may insulin resistance ka na, magko-compensate ang ating pancreas. So, ano mangyayari? Magkakaroon tayo ng hyperplasia. Lalaki ang ating pancreas para to compensate by that insulin resistance, para dadamihan niya pa yung insulin output niya. That's the basic compensatory mechanism of your DM type 2. So, again, ano nga nangyayari sa ating insulin? This is the basic normal use of glucose by your insulin. Insulin enters the bloodstream from the pancreas. Then, your glucose enters the bloodstream from your digestive system and your liver. Anong nangyayari? Your insulin leaves the bloodstream and it binds to your cell. Papasok siya sa ating, didikit siya sa ating receptor, ang ating insulin. And then, in response to insulin, cell takes up glucose which used up as a fuel. Diba? That's the basic function of our insulin. But in type 2 diabetes mellitus, anong nangyayari? Insulin enters the bloodstream from the pancreas, glucose enters the bloodstream from our digestive system or from the liver, and then insulin is unable to bind with cell. Nagkakaroon tayo ng insulin resistance. Kahit meron kang insulin, but your body or your cell is resistant to your insulin, what will happen? Glucose cannot enter the cell. So, anong mangyayari? Glucose returns to bloodstream and there will be increase of level of your glucose leading to hyperglycemia. Sige, in a more technical terms, itong nangyayari, again, there are a lot of factors bakit nagkakaroon tayo ng insulin resistance. It could be brought about by genetic predisposition, lifestyle factors, or obesity. So again, all of these factors may lead to insulin resistance. At first, kahit meron kang at an early stage of insulin resistance, our pancreas will compensate to that insulin resistance at an early stage. Compensatory beta cell hyperplasia, meaning we will increase the output of your insulin. Still, it will lead to normoglycemia. Kasi nga, nagko-compensate siya. Kahit may insulin resistance ka na, not all, it will generate more insulin para mas makatulong pa, para mas marami pang glucose na papasok sa ating cell. So that's why your compensatory beta cell hyperplasia. However, if there is already beta cell failure at an early stage, it will now lead to impaired glucose tolerance. Dahan-dahan nang tumataas ang glucose level sa ating katawan. However, at a later stages, when there is already failure of your beta cells, no matter failure of your beta cells, that's the time that will lead to diabetes mellitus. I hope you understand, ha? From genetic to insulin resistance, magko-compensate na siya. Pero through time, from the early stage of beta cell failure up to the beta cell failure at the late stages, it will technically lead to diabetes mellitus. So let's identify the different risk factors for your type 2 diabetes. Of course, family history of diabetes. No, of course, all of you, you know, meron kayong mga family members na may mga diabetes mellitus. Of course, it doesn't mean na pag diabetic sila, automatically magiging diabetic ka na. Of course, it's part of the risk factor, pero marami pa rin tayong mga risk factors na we have to consider. Next, we have you're having a have a BMI or your body mass index of greater than or equal to 23 kg per meter square, or mga lifestyle activities natin. If you are very inactive, high blood pressure, have abnormal blood cholesterol or lipid levels, or pwede din, you have already history of your gestational diabetes. Your gestational diabetes, yung buntis na mother, pwede din sila that from GDM magiging TM, diabetes mellitus, if this GDM is not being addressed. Kung hindi siya talaga na-address, wala na-manage o tarong, then your GDM after pregnancy, that will lead to diabetes mellitus. And another risk factor is the age of our patient, if it's more than 40 years old. And other factor, risk factor, impaired glucose tolerance or impaired fasting glucose. Again, coming from your Harrison, you're able to identify some of these. Ito yung pinaka-importanting mga risk factors na you have to take note. Family history, obesity, physical inactivity, race or ethnicity. Of course, risk factors tayo, Asian, Pacific Islander, previously identified with IFG or IGT, or your hemoglobin A1C is very high at around 5.7 to 6.4. So, at the level of 5.7 or 6.4 of your hemoglobin A1C, that's already a risk factor for DM type 2. History of your GDM or delivery of the baby, hypertension, HDL cholesterol level, and different diseases. So Doc Von, how do you manage your type 2 diabetes? Of course, as a medtech, this is already beyond our scope as a medical technologist. But somehow, I want you to give an overview of how do we manage our patient with type 2 diabetes. Of course, hindi lang siya basically giving a hypoglycemic agent or anti-hyperglycemic agent, but rather it is a lot of different management regimen. Pwedeng at first, glycemic control ka muna, diet, lifestyle, exercise, and medication. And also, it's not just you are treating the diabetes mellitus. You have to treat other conditions such as your dyslipidemia, hypertension, obesity, coronary heart disease. These are different factors that will also increases your chances of having type 2 diabetes. So that's why you have to address these different problems. And we also have to screen and manage different possible complication. Mga complication pag you are already how many years diabetic, a decade, 2 decades, you have to manage the possible complication, your retinopathy, your cardiovascular disease, your nephropathy, neuropathy. Remember, your DM will affect a lot of multiple organ system. Kaya dapat ma-address din natin to. Pag diabetic ang patient to, we have so many things to remember. We have so many things to really remember. So now let's do a comparison of your type 1 versus your type 2 DM. In terms of frequency, mas common pa rin ang ating type 2 DM noon. Usually 90 to 95%. Age of onset, sa type 1, it's any, but most commonly in children and young adults. So, mas common sa younger age. Type 2, more common with advancing age, but can occur in your children and your adolescent. Diba, napapansin natin ngayon with this, nakikita natin na there are so many children that are already obese and they are already at risk of having type 2. And hindi lang at risk, some of them are really having type 2 DM because of our lifestyle, our sedentary lifestyle. Again, risk factors, of course, marami. Type 1 could be genetic, autoimmune, and environmental. Type 2, ito na yung pagiging sedentary lifestyle. Even at a younger age, pangabata pa. 8 years old, 9 years old, 10 years old, very obese, very taas ang BMI nila. And what will happen? They're already currently having a medication of DM at a very young age. Imagine that. Pathogenesis, we all know, destruction of your pancreatic beta cells, usually autoimmune. And for type 2, usually insulin resistance. So therefore, how do we manage our cases for type 1? Pwedeng insulin, kasi nga, walang insulin, magbibigay tayo ng insulin for your type 1. insulin absolutely necessary. Multiple injection or insulin pump. Kasi remember, type 1, deficiency ng insulin kasi may destruction. So therefore, anong ibibigay natin? We give insulin. For type 2, iba naman. Meron siyang insulin. So therefore, ang bibigay natin is yung oral agents or non-insulin injectable hypoglycemic drugs. Pero we can still include giving insulin as necessary. So in terms of the different classical signs and symptoms of your DM, ito talaga yung dapat nyong tandaan. Your polyuria, your polyphagia, and your polydipsia. Pag diabetes mellitus, tatlong symptoms na dapat tandaan. Your 3 Ps, automatically DM, polyuria, polyphagia, and polydipsia. When we say polyuria, that is excessive urination. When we say polyphagia, that is increased appetite. And when we say polydipsia, that is excessive thirst. So later on sa aking next diagram, we will explain bakit kaya nagkakaroon ng polyuria, polyphagia, and polydipsia ang ating patient. So these are the different symptoms of diabetes. Kindly take note of this. Always tired, always hungry. Ito yung polyphagia, vaginal infection because nalalabas natin yung ihi, nalalabas natin yung glucose sa ating ihi, and that's gonna be prone to different infection, not only vaginal infection. Kasi nga, of course, your bacteria will love glucose, so therefore, mas prone to vaginal infection. Possible sexual problem, numbness or tingling in the feet, sudden weight loss, we will know that later, always thirsty, blurry vision, frequent urination, which is your polyuria. So this will now explain the different symptoms of our patient through the ETHIOPATHOGENESIS. We all know that the pathophysiology of our diabetes because of problems sa ating insulin brought about by insulin resistance or insulin destruction. Pero, ang mangyayari naman, what will happen? Bakit nagkakaroon tayo ng mga different manifestation? It is because, number 1, alam natin, mababa ang insulin or there is insulin resistance. Pwedeng insulin resistance din. And what will happen? There will be decreased utilization of your glucose. So, if there is a counter-regulatory hormone, alam na natin yung effect ng ating mga counter-regulatory hormone natin. There will be increased lipolysis, decreased protein synthesis, and increased glycogenolysis. Because of decreased protein synthesis, anong nangyayari? Nagkakaroon tayo ng weight loss ng ating patient because this will lead to increased gluconeogenesis, formation of your glucose from a non-carbohydrate source. From a non-carbohydrate source including your amino acid which is protein. Kaya nagkakaroon tayo ng weight loss sa ating patient. All of these factors will lead to hyperglycemia. Tingnan nyo, from this one, this will all lead to hyperglycemia. And what will happen? Kasi mataas ang glucose level sa ating katawan. What will happen? Pag mataas ang glucose sa ating katawan, of course, that will be eliminated by our kidneys. So therefore, your glucose will be eliminated by our kidneys. Nagkakaroon tayo ng glucosuria because of increased level of your glucose. Lumalabas ang glucose sa katawan, glucosuria through our urine, and what will happen? Remember, glucose will lead to osmotic diuresis. What do you mean by osmotic diuresis? Your glucose will attract more water. So therefore, ihi ka ng glucose sa iyong urine. Anong nangyayari? It will attract more water that will lead to polyuria. That's the reason why nagkakaroon ng polyuria because of the osmotic diuresis brought about by glucosuria. That is the reason of your polyuria. Now, ihi ka ng ihi, maraming tubig ang lalabas kasi of your osmotic diuresis, the glucose will attract more water. What will happen? Nawawalan ka na ng tubig sa katawan. You become dehydrated kasi lumalabas ang tubig through your polyuria. You become dehydrated or hypovolemic. Then that will signal our central nervous system to stimulate the thirst receptor in the CNS. Kasi nga, ihi ka ng ihi, kailangan mo pa ng tubig. Kasi nga, nawawalan ka na ng tubig, dehydrated ka na. It will send signal to CNS to stimulate your CNS yung thirst receptor. So therefore, nagkakaroon na tayo ng polydipsia. That's the reason of your polydipsia. Again, because mataas ang glucose sa katawan, nalalabas siya sa ating ihi. Remember, your glucose will lead to osmotic diuresis, meaning that your glucose will attract more water. Since nalalabas natin ang glucose, more water din ang lumalabas. And the patient becomes dehydrated. Once the patient becomes dehydrated, your CNS will be stimulated. Your CNS will stimulate the thirst receptor. Therefore, nagkakaroon tayo ng polydipsia. Now, the question, Doc, saan naman ang polyphagia? Remember, ang patient natin, ang cells, di ba? Nakikita natin, kahit it's either mababang insulin or may insulin resistance ka, anong nangyayari? Yung cell natin hindi tumatanggap ng glucose. So somehow, it will stimulate our body that it will need more food. It will need more glucose. Kasi nga, hindi siya nalalagyan ng glucose sa katawan. That's why, as a counter-regulatory or as a physiologic response to that scenario, then it will stimulate your body to do polyphagia. Kaya may increase ang ating appetite because hindi pumapasok ang glucose sa ating cell. I hope you understand the three mechanisms or the three clinical symptoms, the most important clinical symptoms na ma-learn nyo dapat about your diabetes. I hope you can explain out to your mother, to your mga brother, or to your sister, or to your relatives about the polyphagia, polydipsia, and polyuria. Bakit nagkakaroon ng symptoms sila pag meron silang diabetes mellitus. Very good. Now, let's proceed on how we diagnose your diabetes mellitus. So, this is now the criteria for diagnosing your diabetes. For fasting glucose or 2 hours postprandial glucose or your HbA1c. Again, ang value natin, pag fasting, should be equal to or greater than 126. Dapat fasting is defined as no caloric intake of at least 8 hours. So, fasting glucose level. And 2 hours glucose 2 hours postprandial, the value is more than 200 milligrams per dl. So the test should be performed as described by who, using a glucose load containing the equivalent of your 75-gram glucose dissolved in water. So bali, may ipapabigay ka na glucose or bibigyan ka ng glucose load, and then after 2 hours, itetest yung level ng iyong glucose. So if there is an impairment of your sugar or of your glucose level in the body, of course, ang effect niyan, tataas ang level ng ating postprandial glucose level, which is more than 200. Please remember that. This will be discussed properly in your lab application, but I want you to remember this different laboratory application. And lastly, your HbA1c, the test should be performed in the laboratory using a standardized DCCT assay. But remember the value ha, pag HbA1c should be greater than or equal to 6.5%. Again, fasting glucose more than 100 equal or more than 126, your 2 hours postprandial glucose 200 more than or equal to 200 milligrams per dl, your HbA1c is equal to or more than 6.5%. Please remember this value. Pinaka-importante to sa lahat. If ever wala kang fasting glucose result, wala kang 2 hours postprandial glucose test, or wala kang HbA1c, pero ang patient mo has a classical symptoms of hyperglycemia, and with a random plasma glucose level of 200 milligrams per dl, that could also be used as a criteria for the diagnosis of your diabetes. Please remember ha, kahit classical symptoms, ano yung classical symptoms natin? Polyuria, polydipsia, polyphagia, and other important classical symptoms. Plus your random plasma glucose of more than 200 milligrams per dl, that could also help you diagnose your DM. These are the different criteria defining your pre-diabetes: fasting plasma glucose of 100 to 125, 2 hours postprandial glucose from 140 to 199, HbA1c of around 5.7 to 6.4%. So these are defining pre-diabetic stage. Pero for me, no, ang pinaka-importante talaga malaman nyo guys, these criteria for the diagnosis. Ito talaga, these values. Even in the board exam, during medical technologies, you still have to memorize that one. Again, we already discussed this one. These are the values that we were able to discuss. Tama ba? Yeah, it's similar. It's actually from your Harrison and from the American Diabetes Association. And but again, no, magdedepende pa rin yung mga normal values dito sa ating mga different reference laboratory. May mga laboratory na ganito ang normal values not similar with this one because you will really be basing on the machine itself, not on these values. But still, somehow, ang mga values nito is similar naman. Ay, magkakadikit-dikit lang naman. And also, this is just a nice to know na nice to know clinical correlation with your carbohydrates is meron tayong tinatawag na DM type 3. Nice to know lang naman to. Yung DM type 3, they are proposing that your Alzheimer's disease is the type 3 diabetes. This is not still, hindi pa talaga siya really the exact terminology na for Alzheimer's that is already DM type 3. This is just a term, this is just a proposed terminology because they have found out that your Alzheimer's disease daw is related to insulin deficiency and also insulin resistancy. Kaya nga sinasabi nila na your Alzheimer's disease is a type 3 diabetes. But again, this is still a proposed terminology. Nice to know lang naman ito. Ano nga Alzheimer's disease? Are you familiar with the Alzheimer's disease? Again, this is the disease that is most common type of your dementia, yung nag-uulyanin. It is actually a progressive disease beginning with mild memory loss and possibly leading to loss to carry on a possible conversation and respond to the environment. So nagkakaroon ng problem sa control sa thought, memory, and language. Now, we will proceed with our last discussion, your gestational diabetes mellitus. So again, pag sinabi nating GDM, this is any degree of glucose intolerance with onset of first recognition during pregnancy. So your gestational DM happens during pregnancy. Kaya tinatawag natin gestational. So usually second trimester or 6 months. So causes metabolic and hormonal changes. Remember, your insulin do not cross the placenta but glucose can. So ito yung sinasabi natin. It is associated with your GDM will result into associated with increased perinatal complication and increased risk of developmental of diabetes in later years. So pwedeng nagkakaroon ka ng gestational diabetes during pregnancy. And again, as I said, if this will not be managed correctly, then that might progress after pregnancy, after mo maanak, then that would lead to diabetes mellitus. So infant increased risk for respiratory distress syndrome. Kaya nga, ano nangyayari? If meron tayong GDM, high blood glucose level in the mother, that will bring extra glucose to your baby. And what will happen? Ganito. If titingnan natin, sobrang cute ng baby. But you know what? That's gonna be a very problem to the baby. You know what? It's not only a complication for the baby, but also a complication during pagpapanganak, no? Of course, sobrang laki, mahihirapan. Most of the time, pag may GDM, a patient is really advised for cesarean section kasi hindi talaga to malalabas pag a vaginal delivery. Kita mo, sobrang laki. So let's identify the different complications from the mother and from the baby. No, ang cute-cute ni baby, pero of course, this is gonna be very problematic also to the part of the baby. Tingnan natin, ito yung mga possible complication. For the mother, pre-eclampsia, this is gonna be leading to hypertension sa ating mother. So ano magkakaproblema during labor? Pwedeng mag-induce ng labor, pwedeng because sobrang laki na ng baby, pwedeng that will lead to the induction of labor, stimulate your labor kahit hindi pa buwan ni mother, pwede nang mag-stimulate ng labor. Okay, sinabi ko, cesarean section kasi malaki ang baby, hindi niya kayang vaginal delivery. You should be delivered through cesarean section. So, kakaroon ng operation and possible labor complication. Again, pag after manganak ng mother, anong mangyayari? There could be a recurrent GDM pag maging buntis na si mother again. Pwedeng magkakaroon na again siya ng GDM and increased type 2 diabetes mellitus. For the baby, anong nangyayari for the baby? Of course, maraming problema. CNS, cardiac problem, fetal programming. Tingnan nyo, macrosomia, sobrang laki ng baby. Increased fast mass. So these are the possible neonatal complication. Prematurity, pwedeng mapanganak prematurely ang baby. Possible asphyxia kasi nga sa sobrang laki ni baby, hindi na siya makahinga na maayos. That's gonna be result into perinatal asphyxia or respiratory distress. Meron tayong many more: cardiomyopathy, heart problem, hyperbilirubinemia, polycythemia. These are a lot of complication, and the long-term complication for the offspring, possibly obesity, type 1 DM, type 2 DM, and your metabolic syndrome, no? We will go back again. Gusto nyo ba cute ang baby nyo pero maraming complication? Of course, we do not want that. That's why we really advocate the prenatal check-up of the mother. Yan talaga sinasabi natin. Pag buntis ikaw, you really have to do a prenatal check-up. Not just for gestational diabetes, but different diseases during pregnancy, because we do not want that na magiging, okay, cute nga si baby, pero tingnan nyo, ang daming complication, and we do not want that to happen to our patients. Okay? I guess that ends our discussion. I mean, I'm so sorry, medyo mahaba ang ating discussion for our topic sa ating carbohydrates, pero I hope that you're able to appreciate your carbohydrates from the biochemistry, from the physiology. We correlated going down to the clinical chemistry and as well as the different clinical correlates. If you do have any questions, please do not hesitate to PM me anytime. I would really appreciate and love those students na nagatanong, naga-PM sa kuha. I would really appreciate that. One time na nag-PM sa ako sa Telegram and na-confuse siya with a particular topic. Of course, kitawagan yun ako siya and I tried to explain that. At the end of the day, nakasabot siya. That's what I want you to do. If you have any questions, please do not hesitate to PM me. Again, I want to emphasize na please ask the questions in your tawag nito sa ating content forum. Okay? And then what else for our synchronous next week for the carbohydrates? Kasi ang synchronous natin, di ba next week we will still have a synchronous for your carbohydrates. Ang topic natin will be, we will have an activity, a case study activity. So, I want you to be familiar with the pathogenesis, the different risk factors, the ETHIOPATHOGENESIS. I mean, we are able to cover man the important concepts. Kasi nga, gusto namin ulit-ulitin yung mga important concepts para mas lalong inuulit-ulit, mas lalo nyong maintindihan. So, that ends my discussion. I hope you learned something from today. Thank you, everyone. God bless you.